Bismillah ar-Rahman ar-Rahim. In this lecture, we will discuss the lower respiratory tract infection. So, this is our learning objective to identification of different etiology of wheezy child, clinical evaluation for children presented with wheeze, ability to manage common causes of acute lower respiratory tract infection and their emergency presentation, family counseling about home care and preventive measure. So, as we start with a case scenarios, a 4-month-old baby boy is admitted to the hospital early one February morning with a 2 days history of cough, increased breathlessness, and difficulty in feeding. His respiratory rate is found to be 60 breaths per minute, pulse rate 140 per minute, and temperature 37.6. The chest is hyperresonant to percussion, and crepitation and bronchi are heard throughout the lung field. The lower edge of the liver is palpable 3.5 cm below costal margin. So, in this case scenario, we need to discuss what could be the most likely diagnosis. You should summarize the case. A baby is 4 months old. He had first attack. There are no previous problem. And the attack is happened during February month. This is a seasonal month for lower respiratory tract problem. Also, in the history, the patient is not toxic. His respiratory rate is 60, is tachypneic, and there are bilateral bronchi and crepitation. Palpable liver, could be from hyperresonant chest. What comes to your mind in this case scenario? What could be the possible diagnosis? So we will answer the next question in this case. What the most likely diagnosis? The most likely diagnosis is acute bronchiolitis. From the previous case, as mentioned, the age of the patient goes with acute bronchiolitis, and usually it's the first attack or single attacks with the season of the infection, and there are bilateral chest involvement, bilateral bronchi, more likely goes with this diagnosis. So, how can you define acute bronchiolitis? Acute bronchiolitis, it's a common disease of the lower respiratory tract infection in infant. Result from inflammatory obstruction of the small airway, with a severe disease more common among infant age 1 to 3 months. Although the disease can up to 9 months, this is more common at this age group. Bronchiolitis is a seasonal with a peak activity during winter and early spring, and usually we found that other family members is a source of infection. What are the possible etiology? Etiology and epidemiology. Most of the lower respiratory tract, they are viral cause of infection, viral causes. Acute bronchiolitis is predominantly a viral disease. Respiratory syncytial virus is responsible for more than 50% of cases. Other agents include parainfluenza virus, adenovirus, mycoplasma and other viruses. The only bacteria that cause acute bronchiolitis is mycoplasma. So you should remember that. There are some sort of chronic bronchiolitis caused by adenovirus. It's a rare condition. Bronchiolitis is more common in male, and it's less common in patients with breastfeed. So breastfeeding is some immunity against acute bronchiolitis. What are the clinical manifestations of the disease? Clinical manifestation. First, the infant develop a mild upper respiratory tract infection. And in the most of the respiratory tract problem, they start as flu-like illness. The baby has a running nose, low-grade fever, sneezing, then start to develop other signs and symptoms of the disease. There may be diminished appetite and fever of 38.5 to 39 degrees centigrade. Gradually, respiratory distress ensues with a paroxysmal wheeze, cough, dyspnea, and irritability. With an increase in baby condition, he may have irritability in severe cases of severe distress. The infant is often tachypneic, and this tachypnea interferes with his feeding. Baby may get attack of apnea, and it's more predominant in very young infant. So, a very young infant, especially below 2 months, sometimes they may be presented with apnea rather than tachypnea. What we find on physical examination: most prominent wheeze and tachypnea. Most of patients with acute bronchiolitis, they come with wheeze. And the mother says it's noisy breathing. They come with noisy breathing. And sometimes they told them they are heavy wheezer. The baby is playing sometimes and he gets distress and wheeze. On auscultation of the chest may reveal a fine crackles or overt wheeze with the prolongation of the expiratory phase of breathing. So, barely audible breathing sound suggests very severe disease with nearly complete bronchiolar obstruction. When we auscultate the chest and you find an air entry or no good air entry, this is an ominous sign. This means that the baby have a problem. He has silent chest. This is a very severe problem. Other signs is the hyperinflation of the lung, which may permit to palpation of the liver and spleen. So, the liver and spleen may be pushed down by the hyperinflated lung. How can you make a diagnosis of patient with acute bronchiolitis? Investigation. In most of cases of acute bronchiolitis, the diagnosis is clinical. So, baby with first presentation, he was healthy previously. A very young infant from 1 month to 9 months. During seasonal attacks, the diagnosis most likely is acute bronchiolitis. So, we can do X-ray, chest X-ray, may reveal hyperinflated lung with patchy atelectasis. The diagnosis is clinical, especially with first wheeze episode during a community outbreak. And we may get an outbreak every 2 to 3 years of acute bronchiolitis. What are the possible differential diagnoses? This means the differential diagnosis of patient come with wheeze. What? Asthma. The most likely diagnosed patient with acute bronchiolitis is an attack of asthma. How can you differentiate between acute bronchiolitis and asthma? Usually asthma has recurrent attack. There are a positive family history of atopia, allergic rhinitis, conjunctivitis, or history of asthma. Other foreign body inhalation, congestive heart failure, cystic fibrosis, and pertussis or whooping cough. Those could be a differential diagnosis for patients with acute bronchiolitis. This diagram summarizes a clinical approach for patient with wheeze or for wheeze child. We may get either acute wheeze or recurrence. In acute categories, if there are signs of symptom of infection, this would mean could be acute bronchiolitis, pneumonia, viral mycoplasma or chlamydial infection, what extra. There are history of choking, could be suggestive of foreign body aspiration. Other cause of acute wheeze could be pulmonary edema, as of heart failure, or hilar adenopathy that make pressure on the bronchi. Recurrent, either you get asthma or other causes of recurrent wheeze. Patient with gastroesophageal reflux, repeated vomiting and aspiration pneumonia, foreign body aspiration, dyskinesia, dyskinetic serious, some of the immune compromised disease, congenital malformation of respiratory problem, vascular ring, extrinsic or intrinsic bronchial compression by sometimes lymph node, some cardiovascular anomalies, mediastinal mass, and lymphadenopathy, vocal cord dysfunction. All this problem is less common in pediatric age group. What are the complications or the disease course? Most of the patients have no more complication. The course and the prognosis of the disease. The patient may get apnea, respiratory acidosis may occur. Cause of death could be due to apnea or uncompensated respiratory acidosis and sometimes severe dehydration. Very rarely death from acute bronchiolitis is less than 1%. Other higher mortality occur in patients with congenital heart disease, patients with chronic lung disease, and immune deficient patients. So those patients, they are liable to high mortalities and high morbidity and more likely to complicated disease. Even the treatment could be different from other group of patients. Patient with congenital heart, chronic lung disease, and immune deficient patient. What are the lines of management? Most of children can be managed at home, support proper feeding and simple medications. Some children who they have respiratory distress, they may need hospitalization. So most of treatment is supportive. Infant with respiratory distress should be hospitalized. The mainstay of treatment is support. If hypoxia, the child should be received cold humidified oxygen. We should put the patient in semi-sitting position. We should avoid sedations. Tracheal intubation, very rarely we need to intubate the child in patient with respiratory failure or impeded respiration. So unlikely to need tracheal intubation. There are a number of agents have been proposed as an adjuvant therapies for bronchiolitis or acute bronchiolitis. A bronchodilator and it can be given as a nebulizer, example salbutamol, or oral medication or salbutamol syrup sometime. Nebulized epinephrine may be more effective than beta agonist for relief respiratory obstruction. Other corticosteroid There are wide controversy about the use of steroids, whether parenteral, oral, or inhaled. In spite of that, they are widely used. Usually, they are not indicated in previously healthy baby with respiratory virus infection. And the main indication for corticosteroid in acute bronchiolitis is in a patient with strong history of atopia. Ribavirin as an antiviral agent administered by aerosol inhalation has been used for infants with congenital heart disease, chronic lung disease, immune deficient patients. So antiviral medication not for every patient. Antibiotics have no value in acute bronchiolitis unless there is a secondary bacterial infection or bacterial pneumonia. So there are no role for antibiotics. Can we prevent acute bronchiolitis? Prevention. There are what's called pooled hyperimmune respiratory syncytial virus intravenous or immunoglobulin. IM sometimes can be used. An example, Rispigam and blavazimab ausinogist. There's two examples of immunoglobulin, and they are given before the season of acute bronchiolitis for some patients, immune-compromised patient, premature baby. 2 months before the season of acute bronchiolitis can be protective from acute bronchiolitis. The most important preventive measure is meticulous or proper hand washing. Is the best measure to prevent nosocomial transmission. So, in summary, a baby with acute bronchiolitis is a young infant from 1 to 9 months. During the season of acute bronchiolitis, mainly in spring and winters, the first attack, they come with wheeze and preceded by flu-like illness. And mainly treatment is supportive treatment. This is regarding the baby with acute bronchiolitis. Another types of infections in children is pneumonia. There are many types of pneumonia regarding infectious type, radiational type, chemical type. In this session, we discuss only the infectious type pneumonia. So, we start with a case scenarios regarding a patient summarized infection. An 11-month-old girl was presented to the emergency department with a 2 days history of high-grade fever, poor feeding, cough, and breathing difficulty. On examination, temperature was 40 degrees centigrade, respiratory rate about 60 cycles per minute. There is a scattered rhonchi and crackles over the right middle zone of the chest. He had preceding history of flu-like illness for the last 2 days. So, what is the most likely diagnosis? By looking to this case and how can you differentiate from previous one, the baby is look more toxic. It have high-grade fever. He had more poor feedings, and on examination there are localization of rhonchi and crackles on the right zone, and his little bit is older than the previous baby. So a toxic baby with reluctant to feed, unilateral presentation, and high-grade fever. But in your mind, what would be the diagnosis? It's possible a pneumonia, and could be more likely a bacterial pneumonia, depending whether viral or bacterial, depending on toxicity of the patient. So, what's pneumonia? Pneumonia is an inflammation of the parenchyma of the lung. Pneumonia, a significant cause of mortality and morbidity. in children throughout the world, particularly in developed countries. They found that 30% of admission to the hospital due to chest infection. What are the etiology and causes and epidemiology of pneumonia? As we mentioned, most of the respiratory tract problems in children, they are viral problems. So viral pathogens are the predominant cause of pneumonia in infants and children under 5 years of age. A major viral pathogen are respiratory syncytial virus, commonest, parainfluenza virus, influenza and adenovirus. Non-viral pathogens include streptococcal pneumonia, mycoplasma pneumonia, and chlamydia. Those two infections, mycoplasma and chlamydia, are more likely common in children over 5 years, or what's called 5 to 15 years of school age. Other bacterial causes, a group A beta streptococci, Haemophilus influenzae, and Staph aureus. What are the specific risk factors for the development of pneumonia? There are some patients, they get features that make them more liable to acquire pneumonia. First, lung disease, chronic lung disease, especially asthmatic or cystic fibrosis. Some anatomical problems, such as tracheoesophageal fistula. There are fistula and the baby may get aspiration through this fistula to the lung and get infection. Gastroesophageal reflux, disease with aspiration. Baby get repeated vomiting and he may get aspiration pneumonia. Neurological disorder. Those patients, they have difficult to clear the spart secretion and they are weak cough. They're liable to get infection. And immune deficiency disease. How patients with pneumonia presented to us? What are the clinical manifestations? A viral and bacterial pneumonia are most often preceded by several days of symptoms of an upper respiratory tract infection, typically rhinitis and cough. In viral pneumonia, we get fever is usually present, temperature are generally lower than in bacterial pneumonia. The baby may get tachypnea, intercostal, subcostal, and suprasternal retraction, nasal flaring. Severe infection may accompany by cyanosis and respiratory fatigue. On auscultation of the chest, we may get crackled and wheezed. And in viral, usually we find bilateral presentation on the chest, what's called viral bronchopneumonia. In bacterial pneumonia, the vectors differ. There are high fever, accompanied by drowsiness, with intermittent period of restlessness, rapid respiration, and dry cough, and occasionally delirium. In an infant, there may be a prodromal of upper respiratory tract infections and diminished appetite associated with sometimes gastrointestinal disturbance, characterized by vomiting, sometimes anorexia, diarrhea, and sometimes abdominal distension. The abdominal distension could be secondary to the paralytic ileus or swollen air. So the vectors differ. It's more toxic, more ill. There are systemic signs differ from viral problem. What we find on physical examination depend on the stage of pneumonia. In early course of illness, there are diminished breath sound, scatter crackles, and bronchi are commonly heard over the affected lung field. In consolidation phase or complication of pneumonia, such as effusion, emphysema, or pneumothorax, there are dullness on percussion, is noted, and breath sound markedly diminish over the affected lung field. Abdominal distension from swallow air or ileus. Liver may be seen in large secondary to the hyperinflation of the lung. Neck rigidity may be predominant with right upper lobe pneumonia. Diagnosis. How can we diagnose the patient? We start debate on clinical manifestation. Maybe you got fever, cough, poor appetite, distress, respiratory distress. Other investigation can help. Chest X-ray in viral pneumonia is characterized by hyperinflation with bilateral interstitial infiltrations. Lobar consolidation is typically seen with pneumococcal pneumonia. So there may be a batch involvement, batch of infection in bacterial and scatter infection in viral. A white PC count in viral infection may be normal with lymphocyte predominant. In bacterial pneumonia, elevation white PC count from 15,000 to 40,000 with predominantly neutrophy. The definitive diagnosis of bacterial infection requires isolation of an organism from blood, pleural fluid, or lung. And blood culture are positive in only 10 to 30% of pneumonic patients. Culture of the sputum is often no value in the diagnosis of pneumonia. In patients with mycoplasma pneumonia, cold agglutinin are found in the blood in about 50% of patients. So the main diagnostic tool is by clinical and sometimes we debate on X treatment. Many patients can be managed on outpatient basis with mild infection. So mildly ill children who do not require hospitalization, amoxicillin is recommended, and sometimes alternative include cefuroxime or amoxicillin clavulanate, يعني oral antibiotic medication for at least 10 days for simple infection. And school-age children and those who suspect infection with mycoplasma or chlamydial infection is suggestive. A macrolides antibiotic such as azithromycin, clarithromycin, and erythromycin is a therapeutic choice. An empirical treatment of suspected bacterial pneumonia in hospitalized child, we may give parenteral cefuroxime, cefotaxime is the mainstay of treatment. Patients with staphylococcal pneumonia, you may get nematocele on X-ray, emphysema more complicated, and staph pneumonia causes more complicated infection with many complications, even prolonged period of treatment. Initial therapy should include vancomycin, clindamycin, or sometimes we give him cloxacillin or napcillin and stop beta-lactamase, anti-beta-lactamase medication. In viral pneumonia is suggested with mild ill, no respiratory distress is reasonable to withhold antibiotic therapy. If you are sure this is a viral infection, you can withhold antibiotics and observe the patient. In spite of that, 30% of those patients with viral pneumonia, they will be conferred to the bacterial pneumonia later on. So if you are doubt about the infection, you can give him antibiotics. What are the indications for hospitalization for pneumonic patients? Age below 6 months, baby with sickle cell disease, chest with acute chest syndrome, multiple lobe involvement, immune compromised state, moderate to severe respiratory distress, requirement for supplement oxygen, complicated pneumonia, dehydration, vomiting, or baby unable to tolerate oral fluids. No response to appropriate oral antibiotics. Complications: direct spread of bacterial infection within the thoracic cavity, may give pleural effusion or impairment, pericarditis, bacteremia or meningitis by systemic spread.